I'll come out the...
Okay. Right, guys, thank you. We're just about to start now. I think that's the majority of people that are coming now. So I'd just like a big thank you to everybody that's turned up. Thank you for coming. This is our third in-house CPD that we've arranged, and it's going to be about exotics tonight, as you already know. So the agenda for tonight, Ian Sayers is going to be talking to you about taking the fear out of exotic phlebotomy. Then you'll be taking a wee question and answer after that. And then we're going to have Darren Docherty, who's going to be talking about when to treat and when to refer with certain cases that you might see within your practice. There's no fire drills planned for this evening, so if the bell goes off, it is a fire, and the fire exits are all noted, so you can go out whichever door you like. Toilets are just out and to the left. And yeah, there'll be questions and answers with Darren afterwards as well. But I'm sure they'll introduce themselves a little bit better than myself. So enjoy your pizza and enjoy your evening.
Hi guys, I don't know whether I should have helped more. The fire exits are here, here, and toilets are there. Right. Not sure whether we've got the thumbs up. I'm ready to go. Right, so try and help you guys. I'm here primarily just trying to take the fear out of taking blood samples from exotics. I've taught a lot of students over the years, and if I got to stand in the light, I tend to wander, so I do apologise. And quite often I see it in students, I see it in vets in practice eyes. As soon as they're seeing something on the list of consults that's not a dog or a cat, you get... They're reaching for a certain antibiotic, and I'd like to say that enrofloxacin deficiency is not a recognised clinical syndrome. But just try and stop panicking and, and just actually think of them as an odd-shaped dog or cat, if that's what works for you. There are differences, but we don't need to be afraid of them. So I have two jobs. In the mornings, I'm working as first opinion or referral, primarily first opinion exotic clinician as a consultant for a local practice. There's not enough of cases to have me gainfully employed all the time. So in the afternoons, I have a second hat and I work for VPG as their exotic clinical consultant. So I'm not a pathologist, but I know what it's like actually working in practice, dealing with clients, and basically what we're trying to get out of results. So that's why I'm here tonight, and that's why I thought I'd choose trying to get blood sampling, get samples from your exotic patients. It is easier than getting blood from a stone. So hopefully a combination of me clicking this and me clicking my screen, I can see where we're at. I'll just go up a couple of slides. So, like I say, we're trying to take the fear out of blood sampling, first opinion practice for animals that are commonly presented that are your non-cat dog species. As a rough show of hands, doesn't help for those of you online, but rabbits, commonly, you seen a lot of rabbits? Yep. Are you seeing many reptile, avian patients? Yep. So, okay. Most of what I'm going to talk about is really primarily the reptile and avian side of things, because hopefully we're a bit all familiar with rabbits. They are the third most popular mammalian pet in the UK. Sadly, that doesn't mean that they get the same percentage teaching of the undergraduate curriculum, but that's just a different soapbox to be going on. Hopefully, I'm going to give you some practical tips to help you obtain these blood samples from your exotic species, and they're all exotics are in quotation marks, because if you come from the country where these animals are indigenous, then by definition they're not exotic. But it's a sort of a catch-up term that gets used in the UK for anything that's not a domesticated species. I'm going to try and illustrate which vessels to get blood from, and then what's the best thing to do, how to handle the samples, and what to do with them once you've got the blood. I'll be honest, from the get-go, some animals are just... we've been recorded, so it's a phlebotomy talk, so it's easy for me, or I can get away with saying they can be not bleeding easy, because they don't want to spare the blood for you. But also, I'm trying to give you a bit of enthusiasm and encourage you, if you're not doing it already, to start practicing or start taking samples. Because if you're seeing these species, I think all these species deserve the same level of care, of investigation as your cat and dog species. There are slight differences in the sort of timings that we'd be wanting to take blood samples, but I will come on to that. Right, next slide. I'm multitasking here. What do we need to know? Well, what we need to bear in mind is, at what stage should you need to consider phlebotomy? What equipment do you need? And how much can you or should you take? So to answer the last question first, generally speaking, for a typical profile, we need about 0.75, and I say we at VPG need about 0.75 mils in a heparin for a full heme and biochem, including ionized calcium. And I state the ionized calcium side of things because that is quite heavy on the sample size. But it does depend a little bit on the plasma yield you get from your sample. So if they're dehydrated, you're going to get less plasma, so you need a bit bigger blood sample in the first instance. If you only get a small sample, then speak to the lab before you send it away, and put it on your submission form. You can prioritize the tests that you want them to check out first. So if you're worried about kidney disease for your reptiles or your avian patients, ask them to concentrate on the uric acid side of things, and we can try and tailor what we do for your requirements. Where have we gone to now? I'm looking at two things. Right, we've done how much does the lab need? We've just covered that. How is it easy is it really? Well, from me standing here chatting to you, I've been very honest with you. I find it relatively easy. Not every animal wants to share its blood with you, but I've met a few cats that are quite reluctant to do that as well. So don't think of it as been out of the ordinary, and therefore, should you be scared about doing it? You need to respect the animal. You need to respect that some of the samples you'll be taking, you can be doing as a blind stick, and where you're actually taking the sample from, there should be alarm bells going off at the back of your head, which I'll come on to later. Scared? No. Just, basically have a care about your patient side of things. So generally speaking, with your exotic animals, they won't show signs of disease as readily, or we don't recognize the signs of disease that they do show as readily as we do with our cat and dog patients. So if you have a little graph of a nice, healthy, 100% happy, healthy animal to the left, to a less than, I don't know whether this has got a pointer, no, to the dead animal at the other end of the spectrum, your cats and dogs are going to be showing signs of disease that we recognize. So far along the pathology process, livestock, a little bit further on, they'll hide things pretty well. For our exotic species, the vast majority of them are prey animals. They're much further advanced. So by the time we're seeing them, I'll be honest, most of my birds and reptiles, if owners are prepared to invest in investigation, I'm pretty much trying to take samples from them at the first visit, rather than saying, oh, let's see how they go for a few days. We have to bear in mind that reptiles in particular can take a long time to die. So, it can be more challenging. The vessels themselves that you're aiming to stick your needle in are often not as easily visible as your cat and dog jugular, but as we've said, you can have a nice fat Labrador's neck that's probably got a hose pipe that you can be getting a blood sample from. But can you see the damn thing? Not always. So it's not necessarily that different, but you do need a degree of anatomical knowledge in order to know where to prod that sharp pointy thing in the first instance. From my perspective, I always sort of feel when I'm sampling reptiles that compared to dogs and cats, it's a little bit thinner. It seems a little bit more watery, for want of a better expression, than it is for a cat or a dog. The complicating factor that particularly with reptiles, depending where you go, you can get a problem where you call lymphodilution, where it can look even more watery, and that will affect the values that you're getting on your biochemistry. And I'll point out some of the more likely points or sites for lymph dilution later. If you are taking blood samples, it's better to say, yes, we're going to do it, and try and do it early on in your diagnostic workup. Primarily because particularly things like reptiles, if you're holding them, they may not be struggling massively, but you can get a lot of isometric muscle damage that will particularly impact things like your CK levels and those sorts of things. So if you're going to bleed them, get on and get the bloods from them at first. Depending on how exotic you're dealing, I do a number of zoo animals, so a lot of the zoo animals I'm doing, I'm only anaesthetizing them under anesthesia because the species they're not trained, they're not like lions and things. So if you're doing anything under anesthetic, and most of my birds I do under anesthesia because it's less stressful, both for the bird and for me, trying to get it as soon as I can so that the anesthetic's not impacting the values that we're getting, particularly with themes, the likes of hematology, in the same way that we can get with cats and dogs. Asepsis is just as important in exotic species as it is in your cats and dogs. So for some species, though, it can be harder to achieve. Obviously, you remove your gross contamination from the surface initially. How much of that you need to move can depend on species and sample site in particular. As a general rule, your cutaneous bacterial load in avian skin is a lot less than it is with reptiles, so quite often with your birds, quick wipe, a little bit of damp spirit on a swab is adequate, same as you would do with a cat or dog. And you notice I say damp, not a bucket full of spirit. We don't want to be using that on a lot of small animals that then may lose a lot of heat, and particularly we don't want to be chilling our reptile patients. So what you need to do is spend sufficient time with your reptiles, making sure that you're cleaning them thoroughly and that you're making sure that you're cleaning under the caudal edges of a lot of the scales, because we can get debris caught there. So I just use a smooth or soft, gentle toothbrush. I'll use an diluted iodine, about 1 to 50, and we'll give a scrub, making sure I'm getting under the scales, and then just a light wipe with a little bit of damp spirit on a swab afterwards. So we've got preparing a bearded dragon here. You can see the iodine is nicely working into the scales. I'll wipe that off usually with a bit of tissue, and then I'll just give it a little wipe with some damp spirit on a cotton wool gauze swab, etc. We then go, okay, so how much can we take? Well, theoretically, if you're big and you're good enough and you've got a big enough syringe, yeah, all of it. But we don't want to be doing that. What we need to be asking is, how much can we take safely? You'll see in most of the books that it'll say, generally speaking, it's safe to take 10% of the circulating volume from a healthy animal. The question you have to ask yourself then is, if it's a healthy animal, why are we wanting to blood test it? So we're probably doing it from animals that aren't healthy. I'll still aim to take around about 10%, I'll be honest, but you've got to have that little alarm bell in the back of your head thinking, all right, this is likely a sick animal. I can't tell you it's not sick until we've actually got the samples from it. So don't just go draining it as much as you can. Also, bear in mind, if you're doing it as a pre-anesthetic check for surgery, you've got to account for potential losses for surgery as well. So if you take 10% of the blood for your blood sample, when you're doing any surgery, you've only got about 5% you can lose safely before you start going to go into circulatory failure. So if we put that into, has that clicked? No, it hasn't, has it? There we go. So if we want to try and put that into actual volumes, if we talk about reptiles first, their circulating volume is about 5 to 8% of body weight. For birds, it's between 7 and 11%, and mammals, similar to reptiles, so 5 to 8%. All sounds very mathematical, but in actual volumes, that means for reptiles, 10% of the circulating volume is therefore 0.5 to 0.8 of a mil per 100 grams, or 5 to 8 mils per kilo. It's the same thing, it just depends how big your beast is that you're dealing with. For birds, you're looking at taking between 0.7 and 1.1 mils per 100 grams. And mammals, the same as reptiles again, 0.5 to 0.8 mils per 100 grams. So I'll be honest, I sort of have in the back of my head, if I can get it, I'll take about 1 mil per 100 grams. It'll sort of work out, but as we were saying, do be aware. Sorry, I didn't click those down, I'm looking at my screen. We can get circulatory failure at 15% blood loss. So if you've already taken 10%, like I say, for surgery, you've not got there. You've not got that much left. So how much can we lose? Let's look at some different species. I'll admit the big brown thing in the middle isn't exotic, but it's just to try and put it in perspective for you. If you're looking at average figure, we were saying about 70 mils per kilo body weight for your mammals. If we're looking at these body weights, your 50 kilo dog in the middle, rabbits are between 1 to 3 kilos, and your 30 gram mouse. That means as a sample size, or their circulating volume, is around about 3.5 litres for the dog, 2.1 mils for the mouse as a circulating volume, and between 70 and 210 mils for your rabbits. To put the mouse into perspective, your little square swabs, when you're in surgery and you get that horrible bitch spray that bleeds and you find out that you do have adrenal glands still, that'll absorb 5 mils easily. That's the full circulating volume of 2 whole mice and a bit of their friend. So if you're using swabs with your small mammals and reptiles and things, don't use these. Use little cotton buds, put them in the I nearly said microwave then, autoclave, sterilize them, or even you can get the little tiny triangular tipped swabs that they use for ocular surgery. It's much better than just dabbing away with your big swab. Oh, it's stopped bleeding now, because all the red stuff that it needs to bleed is in your swab next to you. So like I say, 15% blood loss will cause circulatory failure. So for your mouse, that's only 0.3 mils. It's not very much we can get from these guys. You can get 0.5 litre nearly from your dog in the middle. So yeah, we don't need to panic that much with a bleedy bitch spray if it's that big. We all do. But we don't need to. And between about 10 to 30 mils for the rabbits. So what sort of equipment do you need? Well, compared to your cats and dogs, it's nothing special. It's nothing different, really. Just really important. Have all your equipment ready in advance. There's nothing worse than getting part way through it and finding you've got something missing. So you need your slides ready, cleaned, so that they're not greasy. You need your cotton wool or cotton buds, whatever it is that you, depending on the size of your animal. A little bit of skin cleaner / spirit, your syringes, your needles. So there's nothing on the list there that's different from a cat and a dog, is there? Or do I just do it different down in Torbay? No? So you don't need to be worrying about it. The only difference really is, with a lot of the species we're looking at, it's the size of the needles. So I have a little range. The 27 gauge I don't use too often, but when you need them, they're really helpful. So with the needle size, which do you choose? Well, as with anything, you want it as large as possible and as small as necessary. So generally, 22 to 27 gauge needles I'm using. If you choose the small one all the time, you won't get a good quality sample, particularly for your hematology, because it relates to the physics of laminar flow properties and stuff like that. In the same way now that hopefully everybody in the room here is taking jugular samples from cats rather than cephalics, because you get a much better quality sample. It's the same thing applies to these guys, only your vessels are much, much tinier to start with. So also, if it's too small, it's drawing slowly, it's more likely to clot. Syringe sizes, I'll be honest, for most of my patients, I'm using a 1 mil. The trouble with a 2.5 mil if it's a small vessel with a lot of birds, because I'll come on to it in a minute, but I prefer to use the ulnar vein. Even a small movement of that plunger can result in quite a big change in negative pressure within the syringe and cause your vessels to collapse. So I tend to take a mil, because as we said at the beginning, most animals, if we can get 0.7 mil, we can get a heme and a profile out of it quite happily. That was just a pause to worry everybody at home that's watching it live that they were buffering, because I'm a bit weird. So how do you now get on to actually getting the blood? Approach angle is really important. It depends on where you're taking it from, but sometimes you've got your needle, then you've got your syringe that's really rather straight, and you're trying to get it into a little awkward angle. So therefore, if you aseptically bend the tip of the needle before you start, you'll get a better access. There'll be some pictures will come up in a minute. It's just a little bit out of order. Before you actually start, it sounds like a really simple thing, but make sure the plunger in the syringe is moving freely first. Because once you're in that little vessel, if it's not moving freely, as it suddenly comes, it can move that needle tip, and you don't want to be doing that if you can help it. Another question that we get asked, it's coming up in the right order, sorry, it's because I'm looking at different screen. To aseptically bend the needle, pull the needle cap off, but don't actually touch the needle itself. Just ever so slightly bend it still with the needle cap, so it's still sterile, and then you can get yourself a nice little bend. If you bend it too much, you'll obviously kink it, make it too narrow, and that'll make getting the blood sample in more difficult and or more likely to cause hemolysis. So it's a little bit of a balance, but it can help. I'll look at that screen more than mine. Ensure the plunger's moving, like I said. And then another question that we get asked not infrequently is about pre-heparinization. So to heparinize or not to heparinize? Is that really the question? I'll be honest, I don't use it. But if you do use it, then once you've got your sample, don't put it in a hep tube, because the liquid in there will dilate it even further, and that will impact the values that you're getting, because it'll be more dilute. So, we've said about bending the needle, the heparinization. Once you actually get going, make sure you're in a comfortable position. That's not just me being an arrogant surgeon. Once that needle's in that vein, you don't want to be moving. So if you're bending over and you start shaking, it's not a good thing. Be comfortable. It makes it easier for you. I ensure that the needle bevel is uppermost when I'm going in. Once I'm through the skin, I usually put a little bit of gentle negative pressure on the plunger, and then when I actually enter the vein, you'll get the little flash of blood, you'll know you're in there. Advance a little bit more to make sure that the whole needle bevel is in there, and then start taking your sample. Maintain the needle in a static position relative to your patient once you're in there. I know cats, jugulars, we can get away with doing this a little bit, but things are so small, we don't want to be causing vascular trauma. If you look close up, this is under the microscope, what these tiny needles actually look like. If you imagine, that's the same as having a little dagger inside the vein, and if you're wiggling it around, it's going to lacerate it, it's going to bleed. You're going to know there's blood in there, but as that hematoma forms, it's not going to go in your syringe to send to the lab. So try and keep it all still, which is why I go back to having them anesthetized for the birds and me being comfortable. So once you've actually got your sample, remove the needle. For reptile and avian species, the best thing is to put it in a lith-hep tube. Lith-hep will lyse a number of bird and reptile species. Sorry, EDTA will lyse. So we do hematology on the lith-hep sample if you've not got a big enough sample to also take an EDTA. But with a number of species, the EDTA will lyse the cells, so you can't do your hematology anyway. And I have to say it that way because somebody might put a hand up and say, EDTA doesn't lyse chicken cells. Yes, I know. But as a general thing, we all stick them in a hep, and then we can do the hem and the biochem on the same sample. I would really, really recommend, if you're not in the habit of doing it, but make fresh smears at the time of your sampling. It makes, even if things happen to clot. I have it myself. I had one the other week. It was in a rabbit, big rabbit. I should have got, what did I say before, between 70 and 210 mils from it. Could I get a mil from the patient, sweet little thing that it was? No. I got just enough, put it in my hip, put it in my EDTA, give it a jiggle, made my fresh smears, hadn't jiggled the EDTA enough, and got a clot in there. At least I've got my slides there that are fresh and have been made. The smears have been made before it's clotted. So, yeah, really, really helpful. On top of that, if you're only getting a hep sample, having a fresh smear, you'll get better staining properties at the lab from a fresh smear than if they make a smear from the slide. Right, we're up with that one? Yes. So yeah, the smears, most helpful, like I say, especially if you get samples, or if you're posting things and it's sat in the post, samples can deteriorate, your dried smears won't. The more you do them, the better you'll become at it. There's lots of stuff. If you look in those of you that have got your VPG users, if you look in the price list, there's tips at how to do it, but basically, little tiny drop on one end. The best way I would suggest is with your spreader slide. I have a couple of spreader slides that I've had for a long time. They've got the edges cut off, so the spreader slide is not as wide as the slide I'm sending to the lab. So when you draw your slide back to the little spot, your little sample, and capillary action shoves it to one side, it's not going to go to the edge of the slide that you're sending away, and you get a much better smear. Using the same spreader slide by cleaning it off between patients over time slightly rounds the sharp edge, it gets it much smoother. So I use the same spreader slide day after day. And that was something I was taught by the hematologist at Langford. He says, if you're using a new slide every time, it's really scratchy and it irritates because you get a scratchy, rubbishy sample. So, yeah, upper slide held is around about 30 to 45 degrees. That gives you a narrower film, and then you want it just to be a nice smooth drag so that you get a uniform thin film thickness, and you get a nice feathered edge at the end so that they've got a nice single layer where they're then doing the differential count so that it's not all sort of clotted up and grouped up into things. Before you actually start taking samples, another thing, because I can talk about sampling, stabilise your patients. If you had a bitch coming in, pyometra that's crashed, would you be taking bloods from it straight away? Probably not. You'd think, all right, gosh, that seems a bit dehydrated. Let's get some fluids in it. Let's start doing this. However, with your reptile patients in particular, it's a little bit more difficult to assess whether they are dehydrated until you've got your blood sample and seen your hematocrit. But you can still make sure that they're nice and warm in their preferred body temperature. That means the vessels will be opened up more. It makes it easier for you to stick something sharp in it. So rectify any hypothermia that we have and get them nice and warm. So that's, again, not different to your cats and dogs. We now get on to, dun dun dun, how on earth, where do we actually stick this sharp thing that I've been telling you about? I'm going to start with chelonia. I would advise your primary site to be the jugular vein because we've got minimal chance of lymphodilation. The vessel itself is superficial, and sometimes a little bit of pressure. I've put in their thoracic inlet because they don't have a diaphragm, therefore they don't have a thorax, so they can't, by definition, have a thoracic inlet, but you know what I mean. If you put a little bit of pressure on where the neck goes into that hard to reach shell part, it can make it stand up. You don't always need it, but it can aid visualization. It's important that once you've got your sample, ensure that you've got hemostasis, or you can potentially get quite significant hematomas. And in order to do it, you can give them a little pressure bandage around the neck. Obviously not so much pressure that they can't breathe, but that would just stop hemorrhage, and then they'll be fine. How long that needs to stay on for, hopefully not that long. You don't need to do it very often, but yeah, it can be quite helpful. So if we look on This one, this is quite a big tortoise, but the anatomy is the same. This is around about, I'll say about 200 kilos, so I'd probably be using not a 27 gauge needle for this chap, but the blue line at the top demonstrates where the jugular vein is. The red line at the bottom is demonstrating where the carotid is. If we then look at a slightly smaller species, so a testudo, hopefully you can see where that line of little black arrows is, and you can visualize where the jugular vein is. If you carry that line on towards the head, it should be in line with where the tympanum is to help you give you a bit of a landmark to go from. It's quite superficial, and once you've got the head out, I would suggest holding the head, have an assistant either holding the legs back or having the fingers within to stop them doing this, because they can create a lot of damage with the scales that they have on the feet. They know what they're doing. Or with them horizontal. So again, the marsh turtle, which is bottom left, you can't really see where we're going, but yeah, you can see where we are on this testudo, and those of you look closely, it's not just an empty syringe. There's a tiny bit of red in the hub of the needle. We did get a sample from it afterwards, but honest, it's a blood vessel. I did get it. So, other sites. If you go in what's called the subcarapacial sinus or the subvertebral sinus, it's midline below the cranial aspect of where the carapace is, and it's just above where the caudal cervical vertebrae are. It's really got a high chance of lymph dilution, because if you go slightly off before it, you'll go through a lymphoid vessel first. So if you start to take a sample and it looking like you're getting a little bit of water, then stop, get another needle and syringe, and go a little bit sort of further back. It's about a 45-ish degree angle that you want to be going at. And basically, insert the needle at the junction of the skin and the shell, and you go in dorsocaudally until you aspirate the blood. And you can do it with the head extended, or one of the reasons that it's beneficial, if you've got a grumpy tortoise that doesn't want to be helpful, you can get it with its head in position, extracted. Not extracted, the opposite round. So image number 1, head extended. We're in the midline. You've got the little, I think it's called the noodle scoot, and we're just going up and aiming to the top of the shell. But we can do it if they want to be awkward, uncooperative, and not extend the head with the head retracted. Other sites that you'll see referred to in the text, I'll be honest, I don't use them, but I'm trying to put them into for a degree of completeness. It's the dorsal coccygeal vein. It's midline above the vertebrae. Because it's above where their cloaca is, it's a really dirty part of the tortoise, so it can be really quite heavily contaminated with fecal material. So you need to spend a lot of time trying to clean it. So why go to the messy end when you can get a better sample from the front end? You'll also see reports that talk about a brachial vein, femoral vein, and you can go for the heart or possibly the carotid artery. Hearts, it's more if you're thinking about doing euthanasia of juvenile tortoises that have still got a nice soft shell, and you can just go between where the scutes are actually forming. I wouldn't recommend it as a primary site to take blood samples from, but you'll see it referred to, so that's why I mention it and move on. Lizards. Again, I would be going at the back end with these because they've got a longer tail, whereas your tortoises has got a short, usually dirty, pooey tail quite often. So my first site I'd go for is the ventral coccygeal vein. You want to be proximal enough to the cloaca that it's still quite a large vessel, because the more caudal you go on the tail, it's getting narrower and narrower, makes it harder for you to hit, but not so far forwards that you might well be impacting and catching the hemipenes. You shouldn't catch the hemipenes because they should be lateral and you'll go in midline, but if you can be a little bit further back so you avoid any potential issues, why not do that? So generally speaking, as you saw me with the image earlier, you'll see in a second with the bearded dragon, with most lizards I'll go ventrally. I don't know whether any of you still, I'm going to show my age now, but do they still do brucellosis testing in cattle? Oh God, a total look of blanks. I am that old. Okay, I was going to say, it's the same thing as sampling a cow. You go in between this, I'll get the next picture up to try and show you. Go in between the scales. Same if you're doing surgery with reptiles, you want to cut between the scales, not through them. As a surgeon, as an aesthetic side of things, I hate it because the wounds that I stitch up are just all raggedy edged, and I don't like it. And with reptiles, you have to invert them anyway to get them to heal. So you get this sort of raggedy lips, but cut, it's awkward, cut between the scales so that when they're shedding in the future, there should be less issues of scarring and potential of dysectasis problems. Similar approach with this is that we want to be going between the scales. We're going in the midline, going at about 45 degrees to the vertebral column, and you should, if you go too far, you should feel it hit the bone, and then you just draw it back a little bit, and you should be in the blood vessel. Unlike a lot of cattle sampling I did when I was newly qualified, when you hit the bone, your bearded dragon's not likely to kick you in the leg and break your shin or anything like that. But it's the same principle. However, if you're looking at something like, let's say, a chameleon that's got a bit more of a laterally flattened tail, you can go in laterally to it. We're aiming for the same site. So if you're looking at a thin tail that's this way, you've still got your transverse processes of the vertebral processes that are this way. You're aiming to go in just below and go up, and you're aiming to hit it from this angle as opposed to hitting it from that angle. It's the same vein, but just because it's a flattened tail, you need a smaller, it's just easy, you've got less tissue to go through. Other sites that you can go for, and like I say, this is more really for completeness, because I've never gone for a jugular vein, I'll be honest, but it, again, as with cats and dogs, point of the shoulder to the angle of the jaw. There's talk about the ventral abdominal vein. I would advise avoiding that full stop, whether you're trying to get a blood sample or if you're doing coelomic surgery. And it does annoy me that it's called the abdominal vein because, as I said, they don't have an abdomen. But hey, it's actually a coelomic vein. If it does bleed once you've taken it out, the only way you can perform hemostasis is to open the coelom fully, which is, it strikes me as being a bit excessive if you're just trying to get a blood sample from it. Cardiac sampling, I've never done it to get a sample because I've been able to get them from veins, but I put this up more as an idea to show you that the position of the heart is quite caudal and quite cranial. Can't talk tonight. It's usually more around the pectoral girdle area in the midline, and if anything, I'll use it as a top-up site for euthanasia, which is what we've got in the picture here. So we can see it's all black, it's got no writing response, it's on its back, but you can see the Doppler at the top of the picture. We're checking that it's dead because with reptiles, and you need to make sure that you've got a negative heartbeat before you pronounce death, because their heart can beat for quite a long time. If you post-mortem them and take the heart onto the table here and stroke it, and the animal's here, it will still start to beat. It's got a massive intrinsic ability to do it. There are situations where animals have purportedly been pithed, chelonia, pithed, euthanized, pithed, and then in cold storage for 48 hours that were then subsequently used for ultrasound practicals, and they still had heartbeats. So please make sure that there is no beat either by a Doppler or by ultrasound before you're happy to say that it's dead, particularly if your clients want a home burial. So I'll use it as a top-up. So that's why we've got some euthatal in the syringe. We've got a nice flash of blood, and I'll just give it a top-up there. That'll usually stop things pretty quickly. But again, it's once it's got to the state, it's anesthetized. I don't use it as my primary site. We'll then talk about brachial plexus, as we said before. Never used it, but you could possibly, I think, go for it for some of the bigger species, but again, it's more, I've put that on in for completeness. Snakes, if it's a big enough snake, again, I'll aim for the ventral coccygeal vein, very similar to we were talking about with lizards. Same sort of approach. This is sampling, and we've got a nice, happy, I mean, that's my hand, so that gives you a scale to the size of the snake. It's not like it's a 20-foot python or anything. And we've got a nice mill sample coming from there. I'll use that as a preferred site for administering propofol for anesthesia as well. If I can't get a tail, if I don't think it's big enough, then I will do cardiocentesis. The data and the studies that are out there is that it's relatively safe, and there's a little bit in a minute that'll show you I'll tell you about how safe it is. But fortunately, they've got a thicker muscle wall, so therefore it's less likely to bleed after sampling than a lot of mammals. The heart is quite complex in reptiles. It technically only has 3 chambers. It has 2 atria and 1 big ventricle, but the muscular folds within it can make it act as a 5-chamber heart, which I find quite fascinating, and that's why they can withstand hypoxia, because they can keep shunting blood around the body without it needing to go to the lungs. But there's still that little bit in the back of my head. Don't be complacent about it, because I'm aiming to stab something sharp in an animal's heart. It doesn't sit well. Difficulty, though, can be actually finding the position of the heart can be quite variable. Generally speaking, it's between about 22 and 30% of the length of the body. So that's from the nose to the cloaca, the body. First of all, you've got to locate it. If I've got a relatively big snake and I've got enough nursing staff around, we're doing this, and there's 2 or 3 of us looking on the ventral surface to see if we can see it beating. Hopefully, if we see a beat, it's got a nice, on a corn snake, for example, it's got a nice little shape on a scale so that we know it's that scale. If not, we'll sometimes put a bit of sticky tape or something on it there so that when we've scrubbed it, we can see that it's still in the same position rather than it's moved. If you can't see it, then you can get your Doppler out, or you can use an ultrasound. Once you've found it, you want to stabilize it with gentle digital pressure. So this is just showing roughly the positioning. This is a snake that I'm about to operate on, not take a blood sample. So we can see we've got the snake's head taped to the ventilator at the front end, and therefore, well, we haven't got the tail, and you can see that big lumped caudally. That's what I'm interested in. But we've got the Doppler on there. It's the loudest bit that we get in to actually find the heart. I use it for anesthetic monitoring as well. So stabilize it by gentle digital pressure. There we go. Again, go between the scales, generally at about a 45-degree angle. Once you're through the skin, again, a little bit of gentle negative pressure. And when you enter the single ventricle that I mentioned before, again, keep it static in relation to the animal. Bear in mind that this is a moving organ, and if needs be, try and move with it a little bit. Equally, you might need to apply your negative pressure in synchrony with a heartbeat to actually fill your syringe up. And yeah, good technique is associated with minimal morbidity and mortality. So don't worry too much, but I think it's just sensible to be aware that sticking sharp objects into hearts isn't good. So again, this was a very helpful corn snake in that we could find out where the heart was because it had black band, white band, black band. So once we'd seen it, that was great. And again, stabilizing it with a thumb, going through between the scales, and you can see the little flash of blood in the needle hub as we're starting to get our sample. Other vessels that they'll talk about is the palatine vein. I'll be honest, it's something that you'll see when it's under anesthesia. Would I say it's a site to be getting blood from? No, but again, I'm just trying to be thorough. It's very delicate, significant potential for hemorrhage, and those of you that got anesthetized snakes, we can see it in this position. So it's not the easiest of places to start sticking a needle and syringe. But you'll see references to people saying, well, you can bleed them from it. It's not where I would go. And they're not always symmetrical, as we can see in this corn snake. Birds. This is a little bit quicker because they're not as diverse than their reptile friends. I usually go, like I say, prefer to go for the superficial ulnar or the basilic vein. It's usually fairly obvious, so this is in a tawny owl. This is just with a little bit of spirit on the feathers to dampen them to fold it back, and we can see it quite easily. Some of our patients that come in are really helpful, and if they feather pluck themselves, they're just like a walking anatomy thing, like this macaw, so we can see where we want to stick the needle without having to use any spirit at all. But you can also do it in smaller birds, so that's a dove. Again, it's a relatively easy site to get. As a general rule, if I've got a parrot, for example, I'll be doing these under anaesthetic because it's less stressful for the parrot and for me, because I don't like getting bitten. I like to keep my fingers and thumbs. If I can't get it from a parrot in its ulnar vein, it's not, this is me just anecdotal. Generally, when I get results back, they're quite a sick bird. So if I have to go for a jugular, I'm already thinking, that ain't good. But there are situations where if you can't get those, then go for the jugular. So it's a different tawny owl that I was showing you there. With this, it looks like there's a great big area. I haven't plucked it. Birds have natural areas without feather called aptera. Use it to your advantage. Their skin is very mobile. So you can find the area with no feathers and you can stretch it over and move it over to where the vessel is, and you should be able to visualize it, and then just give it a little light wipe with a bit of spirit. So we're not needing to pluck them. And I'm not plucking them on the ulnar. I'll just damp stuff away. Other birds, in case you've seen a bit more exotic, they don't have aptera, so this is on a penguin. This technically is a blind stick. So what we're doing there is trying to get all the organs of the neck in one dimension. So it's like this, so therefore I know we've got the windpipe, we then have got the esophagus, and then we should have the jugular, and that's where we're getting the blood from. So it's a blind stick. Much bigger bird than we were talking about before, but we're still using a blue needle rather than a green. That's probably an inch needle because we've got quite a lot of tissue to be going through. Medial metatarsal veins, really useful. On something like this, I'll be honest, I can't remember what seabird that was. It was a wader of some sort. We can see the vein going down the leg. I'd still probably go for a blood sample. I'd go for the ulnar or the jugular, but it's not a bad place to be trying to use if you're thinking about having to euthanize wildlife, because we've got ready access to it. If any of you deal with swans, that's the one to go for. Don't bother with the wings and stuff, because you need to anesthetize them to get them still. They're like hose pipes on a swan. But yeah, a lot of wildlife casualties, I'll use IV pentabarb on the medial metatarsal vein. There are other situations that you can think about using pedal or digital vessels. This is a image that has been loaned to me. If I was doing that, I'd have it a bit cleaner. But I think they've got to the frustrated point that we are going to get some blood from this penguin, and they got it well from this vein. But I'd go for your ulnar or your jugular. Rabbits. A lot of you were saying you're getting rabbits. I'd really advise the lateral saphenous. Is that what you guys in the room are using? A few nods? Yeah. Just bear in mind, it's really delicate and it can bruise like bilio. So I have my nurses ready to put a lot of pressure on as soon as I take the needle out. Generally speaking, apart from the patient I was talking about the other week, I like to think I can treat it a bit like a cat's jugular, and I should be able to get a couple of mils quite readily, like we've got in the picture on the right. I've got a number of colleagues that prefer to use butterfly catheters and let it drip into the blood, into the sample pot. Hey, if that works for you, fine, but it should be a substantial enough vessel, but it is delicate and will bruise. Jugular, yes, you can use it, but bear in mind with the females, the dewlap can be quite big and it can get in the way. So that's why I would say I go for the lateral saphenous. Caudal ear vein basically is too small for you to take stuff out to get a quality sample, but it's great for putting things in. So I'll use that as my primary site for catheter placement and things like that. If I can't get a caudal ear vein, then I'll catheterize the lateral saphenous. And you can use the cephalic, but again, a bit like the ear vein, same as with cats. I'd rather go for a jugular. It's a bit small. I usually use the ear vein. When I started working at Langford, I said to the nurses, can you just pop a catheter in one of the rabbits? And she brought it out to me with it in its cephalic, so I was very impressed. Surprised, but very impressed. So I find the ear vein much more straightforward for catheterization. Ferrets, primary site would be jugular. Potential for anterior vena cava for sample larger volumes. It's not a technique I use that often, I'll be very honest with you. But if you are going for it, or the branch that drains into it, you're wanting to insert your needle into the thoracic cavity between the first rib and the manubrium and direct it towards the opposite rear leg / the last rib and insert to the hub. As you then gradually withdraw it with a slight negative pressure, monitor for a flash of blood into your hub, and you should then fill the syringe. There's often a comment that says, if any struggle, remove the needle and wait for the ferret to settle. Well, with the blood sampling the ferret, I don't think you'd need that caveat on there. I've never done it. If I was doing it, I'd probably want them anaesthetized because I think it's much nicer for them, for the position and things. Apparently, it can be done on conscious patients if you've got an adequate number of assistants, but if you're worried about stressing them out, then anaesthetize them. They go to sleep quite quickly. If you're doing a jugular sample, you can do that conscious, and again, that's a really bad picture to show. It's an old picture. There's no blood in it. All you can see me is blindly sticking a needle into a ferret's neck. We did get a sample afterwards, but a bit like that. But that's the one that's anaesthetized, which is why it's on its back. So it depends how distressed the ferret is doing it. If you are inducing them in a chamber, don't use the same one that you might use for your small mammals. I was about to say don't use the one that you might use for your rabbits, but I would say don't chamber induce the rabbit because of the breath hold. It's really bad. Not nice for them. Use injectables. But you don't want your induction chamber smelling of a predator, particularly if rabbits are associated with it. It can be sufficient to cause them respiratory arrest. So, avoid it. Anterior vena cava. So, we restrain them in dorsal recumbency with the forelegs drawn caudally and the head and neck extended, as we were describing before going across. Again, cephalic vein. It's a place you can catheterize for giving stuff. I would say it's not really of a substantial enough a vessel to be taking stuff out. And then, lateral saphenous vein, again, okay for smaller volumes, say if you wanted to be just getting a little bit for checking a PCV or maybe a glucose stick. Guinea pigs and chinchillas. How many of you guys have clients that will let you regularly sample their guinea pigs and chinchillas? A show of hands. None. I will join you with that and firmly have my hands in my pockets. Have I got clients that will fund it? Not to date. We do get a number through the lab, and I'll be honest, that really surprises me because those vets are obviously much more convincing than I am. But again, jugular sample. But guinea pigs do have short little necks, so forelegs extended, head and neck extended, like a cat. Cranial vena cava, similar to we were talking about with ferrets, yes. Lateral saphenous and cephalic, it's only really small amounts of blood as they're small vessels. Doing a jugular sample restraint for a guinea pig can be very stressful, so bear that in mind as well. Oh, I'm looking at two things. Sorry, I didn't click that. Shall I leave that up for a little bit? I'm trying to multitask. it means you do more than one job badly at the same time, doesn't it? Okay, happy? I've done more rats. They have a really nice lateral tail vein. It's surprisingly easy to get a blood sample from. If you're at all concerned, what you can sometimes do is just put the tail in a little bit of warm water, helps vasodilation. But yeah, I've done that more than I have with guinea pigs, I'll be honest. Potentially, you can do saphenous venipuncture for blood sampling in mice, in rats, hamsters and gerbils, guinea pigs, ferrets and mink, apparently to the article in Lab Animal Science. And they're the volumes that we can use for those. That's what the asterisk is, the reference I was talking about. Again, they're really quite small volumes, but you've got to bear in mind that they are quite small beasties in the first place. And that's, if you I'm going to be honest, because I usually am. I don't do a lot of blood sampling of animals that are less than 100 grams, because I can't get enough sample size in one draw to get a profile. So that means I have to start guessing what I might think is wrong with the animal, and therefore test those actual parameters. Well, if I'm going to say, oh, this has got kidney disease, can you concentrate on the kidneys? Why don't I just think, well, it's got kidney disease? That might be wrong. I might not be a proactive enough clinician. I'm very honest. But if they're less than, for the volumes we talked about before, 100-gram animal, you can get a mil. Less than that, you're then talking about having to serially sample. And when I start talking about serial samples to my clients, most of them go, no, we don't want to do that. So you can take a little bit, concentrate on these, and then when it recovers, hopefully, take a little more and get the lab to test these. When it's hopefully recovered its blood volume, another blood sample, and take a bit that way. So it's not something that I do, but it's something I'll offer, but I've never had anybody take me up on the offer. For some of the more exotic zoo species, a lot of the time I'll be using a femoral vein. It's quite often, it can be a blind stick, depending on what sort of species you're dealing with. Basically with that, I'm using feeling in the femoral triangle. I'm feeling for a femoral pulse, and then I'm aiming my needle towards that femoral pulse, but deliberately missing it because I want to hit the vein and not the artery, because trying to stop it bleeding from the artery is a lot more complicated. I do that with quite a number of species, particularly I would say a lot of the primate species. They often don't have a lot of hair in that area. It's relatively easy to clean. You don't have to clip so much, and a lot of zoos don't like their exhibits clipped because they don't look right to the public. I've clicked too quickly there. We can go back. No, I can't go back apparently. There we go. It'll do it now. Was that a bit of a rapid rattle through for you? Was that okay? Any questions? Stunned into silence. I prefer that than bored stupid. That's a big mouse. I'm glad you said about geckos. I've seen a number of leopard geckos. They're too small to have your 100 grams to get a blood sample that's actually effective to do stuff. The other complicating factor is where you're going to get it from. I had a chat with a colleague I've known, and he says, I just go for the tail vein. And I went very quiet. I said, have you never had them shed their tail with you? And he said, no. I said, I have. Fortunately, the one that did it with me was whilst I was trying to euthanize it, so the owners weren't there. They didn't want it back. It surprised me quite how loud the crack was as it shed the tail, and it wriggled on the table long enough for me to go out to my car back in the days when we didn't have smartphones, because I am such an old person, get the video camera out of the boot of my car, to go back into the room to video it still wiggling on the table, and I still use that in some of my lectures. It's quite dramatic. So yes, with leopard geckos, be really careful. Whether he's been quite so gung-ho in taking tail samples after I had this discussion with him, I don't know. But yeah, do be careful of those that autotomize. But yeah, as a lot of the time, I'll be honest, I don't. Clinically, I find it very difficult to convince an owner to put their hand in the pockets when I can say, we can maybe test 2 or 3 things, and if that comes back normal, what we're going to have to do? We're either going to have to wait. Well, if it's ill, it's going to get worse. And if that's the situation, we then have to say, okay, we're going to have to start at least thinking about some symptomatic therapy if we haven't started that already while we were waiting for the first results to come back. If we've already started therapy, that might impact if we then take another sample. So that's my view. I don't know. I'm quite happy to discuss that within the room. If you all stand up and say, no, you've been rubbish, you need to be better and do it all the time, then I'm quite happy to discuss that. But I feel I can justify the decision-making process that I'm doing, both with the room and with my clients, and I record it in my notes that we've discussed the limitations. And again, unfortunately, within the world we live now, those contemporaneous notes are really, really beneficial. And I would describe them as them being essential. Always offer to do stuff, and if an owner declines to do it for whatever reason, make a note of it. Because when I first qualified, if something didn't improve you, if it doesn't improve, come back. And they'd come back and say, oh, okay, well, we can try this. More and more now, people say, you told me it'd be okay, and it's not. Now you have to pay to do what? No, that wasn't the conversation. This is what we discussed. It's in the notes that were made at the time. Maybe people aren't as litigious up here and are all happy, but yeah, that would be my advice. Yes, my love.
If you're going to serial sample from something, how long would you leave it between doing your next sample?
Not a straightforward question, because it depends on the species. The reason I say that, for something like a reptile, the lifespan of a reptile blood sample, I'm now having to go back, is something like about, I think it's up to 2 years. For a mammal, it's more like about 30 or 40 days. So if it was a bird, a small bird, I'd probably say, I'll be honest, I'd look at the red light, the lifespan, therefore how quickly they're likely to regenerate, but maybe a week. But if you've got a sick bird, it might not have a week left, because if you're seeing sick birds and they've got weight loss and things in particular, a lot of the time, because of the little graph I showed you at the beginning with the whereabouts they have the illness, the pathology has already progressed to a state where, particularly with birds, they've got to a point that they're so ill they can't hide it anymore. So we can't necessarily get them all back. So typically, if you get a sick bird that's coming in, I don't look at the bird if I can for the first, well, because I only do exotics in the UK now. I do cats and dogs in Lebanon, which is why I support this charity. Quick plug. So I'm actually I can take a bit longer. If you've got a 10-minute consult, you can't really do it, but try and ignore the bird, because it's going to come in as a prey animal, and it's going to be in its cage, and I'm somewhere strange, and I'm really quite fit and healthy. You're not going to predate me, and then when you've been ignored, and then they go, actually, I feel really quite rubbish. So I'm trying to watch them while I'm talking. So it depends what their response is on that side of things, because they'll mask it as a prey animal, if that sort of helps. Well spotted. I'm just an awkward so-and-so. It feels weird for me going the other way. if you're looking at them, I'll be honest, I tend to go for the left personally, but the right jugular is the bigger vessel in a number of species, which is why I show the pitch. But I just feel really ham-fisted doing that. That's just me. It's the same way with rabbits. I'll go for the right ear and I'm going perpendicular when I'm putting catheters in. It's just, it feels easier for me, but yeah, each to their own. That depends on the species again. Let me just put my cable down there. If it's a testudo species, a lot of the time, a little bit of patience. With the testudos, if you effectively attack the back legs and they withdraw the back legs, they can't get the front end in fully. So if you have somebody attacking them that think, oh, it's going to get eaten, I'll retract those and the head of the neck comes out a little bit. If you can then get the head, or you can get fingers, we're not trying to pull the head out because we don't want to cause muscle damage, and we're not like this on them trying to get the head out. Once we've got the head, we're trying to hold it still. So if you're going to get behind the back of the skull, where your fingers are narrower, and just hold it, a bit like a yoke on a cattle crush. It's not squeezing the cow's neck, it just can't get its head back in, and then just hold it. The idea being that hopefully their neck muscles will fatigue before we do. That's not always the case, and they'll move it a little bit forward and a little bit forward. If you go ventrally, they're less likely to think that you're a predator trying to eat them from above, and just try and do it that way. If you're telling me it's a leopard tortoise, that's what we have the pharmaceutical cabinet for, because a lot of time we have to sedate them. Depends what you're trying to do. I had one lady come in the other day, and I just wanted to swab it for respiratory viruses, and it was a leopard tortoise as opposed to a leopard. And we had it in. We put it in the Viv, and I just gave up. There was no way. They can get their legs, heads, and they just bring down the shutters. And I rang the owner up and said, we've got two choices. I can start sedating it, which I think is a bit excessive to put a dry swab, or well, not dry, but a damp swab in its mouth. Or you can come back tomorrow and we can try again. Which she came back tomorrow and it was amenable. Did I do anything different? But it's just gentle pressure and then holding them. It's a thing I often do with clients when I'm trying to get them to hold them. So I'll get them to hold the thumb out, and then I'll just hold their thumb here, and then say, right, now try and pull your thumb through my fingers. And I'm not squeezing them. And I said, that's how you need to hold your tortoise's head for you to be able to give the aforementioned antibiotic that is very good, but is not a clinical syndrome, if you're giving it daily. Because for tortoises, if you're giving them antibiotics, a month's worth is the equivalent of a cat or a dog being on it for a week. So it's just trying to get them to use it and just holding it that way. Anybody else? No? Well, I've had some questions, so I can't have been that scary for once. I'll take that as a win.
Thanks, Ian. That was great for somebody whose knowledge of exotics is very limited, and I mean very limited. I've got a lot of takeaways from that. Thankfully, where I work at SVR, there's a couple of nurses that are really interested in exotics, so I will still be very minimal. But I would like to introduce Darren Docherty onto the stage now, and take it away.
All right, let me just get my bearings here. There we go. Right, good evening, everyone. Thank you, Ian. That was an excellent talk. I hope that has helped plenty of people in the room. The reason why I looked afraid earlier is because I'm always used to leaning on podiums, and I suddenly realize I'm probably going to fall over. So bear with me, guys, if I'm a little bit wobbly here. It's just a habit. Anyways, so I want to talk to you tonight about exotic animal medicine. You know, what can you do in practice, what we do on referral. It's a little bit more vague than that, but I'll talk to you about that in just a second. So I want to give you a brief overview on the general approach. You guys are seeing patients day in and day out. So a lot of, how to conduct a physical exam, you will already know that. How to take a history. What I want to point out is a couple of things that I feel are often missed with exotic animal patients. Beyond that, I do want to express quite strongly, this is by no means a full list. Each one of the things I mentioned here tonight, I could talk for a number of hours about each of these, let alone, days or weeks on some of these topics. So I'm trying to give an overall overview. This is going to be something where hopefully we have more talks. I'd be curious to find out what you guys are seeing in practice and what you want to learn about in the future. So, one of the main things we think about in general practice is, what do we need to be prepared for? What are we going to treat? Obviously, we need to have emergencies fresh on our mind. You need to be prepared for the critical patients that come in. We'll talk more about it in a little bit here, but I especially think that with my avian species, if you see an unwell bird, there's a fair chance that it could be an emergency. You need to be prepared to advise thereafter in terms of what types of treatments are needed, what type of referral may be necessary, or whether it's being hospitalized in-house. Obviously, there's a lot of general conditions. We'll talk more about rabbits in just a second, but as noted previously, there's a lot more rabbit owners in the UK and worldwide than there previously has been, and I know a lot of you are very comfortable with rabbit medicine already. General practicing vets have a lot more exotic knowledge than they used to. I do feel like the way it's being taught in universities is better. There's a lot more CPD out there, which hasn't been present. With that said, I think it varies practice to practice, and indeed veterinarian to veterinarian. But there is a lot of transferable skills, obviously. You guys, like I said, you do this day in and day out on a number of different species. I know primarily dogs and cats, but that doesn't mean that you can't use a lot of that. As Ian mentioned, a lot of people, as soon as they see the word reptile or bird or anything else more unique, a lot of people get that deer in headlights look. And I agree, a lot of people suddenly think, oh, it's just a little bit unwell, I'm grabbing for the enrofloxacin. But it's not as simple as that. Do try and remember all the skills you use every day in all the other species. So, with my third slide, I'm almost negating my title. When do we refer? I can't answer that. There is no defined line. That comes down to each one of you and how you feel about the case, where your comfort level is. Think of it, I'm sure a lot of you have an idea what I'm saying here when I say there's some people in practice who feel very comfortable doing a cruciate repair, and other people who feel that is absolutely a referral job. So, similar to exotics, I know some people who would not consider themselves an exotic clinician, but they feel quite comfortable doing a lot of different exotic animal surgeries or medical workups. Similarly, there's people who wouldn't really want to touch it if they don't have to. So, that is a line where each one of you will determine on your own feelings, and indeed in different practices depending on how you're set up. That'll be depending on your comfort level and experience. There's another couple of factors here. Obviously, owner finances are always a factor. When I started doing exotic animal medicine, one of the ways where I got a lot of my experience is I offered referral. But I said, and there's plenty of people who said, well, okay, you give me the cost, I can't afford that. Therefore, I did it, gave them the risks, said I have not done this nearly as much as the referral specialists, but I can do it. So costs are, always a factor. Additionally, fear can be a factor. Now, I have this photo here because I have worked with several nurses and indeed vets who have different phobias. I've worked with 2 different nurses who have bird phobias, which were quite severe, which gets very, you're one of them, right? We'll have a chat later. There's 3. So there, unfortunately, the phobia can be quite intense. I also graduated with a veterinarian who has an absolute phobia of fish. I like fish. I do a lot of fish medicine. If you have her in the building whenever you are trying to anesthetize a fish, that's not going to go down well. So I'm talking about it more from a, as I said, from a fear perspective, from they don't want to touch this because it's way out of their comfort level. And I get that. There are plenty of things with dogs and cats which I wouldn't do. But if you do have at least other people in the practice who might have different enthusiasms, you can also bounce around cases as well. So, where do we start with all this? One of the main things you're going to hear me talk about is diet and husbandry. Now, this isn't a diet and husbandry lecture. However, this is one of the biggest factors I find in exotic animal medicine, particularly when we look at our reptiles and birds. Unfortunately, there's a lot of owners out there who either impulse buy or they think it's very cool to have certain pets and they don't actually do the research. You could say that about any animal ownership in some contexts, but this particularly is the case for exotic animals. And when I'm saying this, I am thinking more about reptiles and birds than any of the rest, but I do see this across the board. You do need to also worry about husbandry with things like aquatic animals. They have a very sensitive and intimate relationship with their environment, more than we do with the air, I would argue. So that's another factor as well when you look at things like fish tanks. There has been a large increase in the knowledge base over the past several decades in terms of husbandry for a variety of species. There's different campaigns out there now with rabbits in terms of keeping the rabbits in certain size enclosures. And I'm sure some of you have seen those from the rabbit welfare associations. Keep in mind, this can very much vary from species to species. Even some similar species, in terms of how you view them, can have very different requirements. Diet is probably one of the biggest concerns. Unfortunately, there are so many issues that turn into a veterinary problem eventually because of the diet. So if they don't get the diet right, and there's a lot of people who unfortunately don't, they will probably have a trip to the vet at some stage. And just, again, remember, there is a large variation between the species. We need to look up the specific diet and husbandry requirements if you have an animal walk through the door. There are so many good guides out there these days, and we can help supply you with those. But there's a lot of information out there. It's just a matter of where to find it. You don't want to go on necessarily a forum where someone's just talking confidently but doesn't know what they're talking about. You want to make sure you're getting it from a reputable source. So, what next? Again, you guys take histories every day. You're listening to clients every day. What I'm mentioning here is a couple of things that I feel are sometimes falls through the cracks when we're looking at exotic animals. So again, diet and husbandry are part of that initial history, but what you want to look at is the enclosure. What's the enclosure like? Are they primarily in or out of that enclosure? For example, are they running around the house? Are they getting the same heat, lighting, etc., depending on what species we're looking at? Is there UV light provision? Now, for some species, I'm less concerned about that, but for some species, that is absolutely vital. You also need to think about the UV lighting. How often are they changing these bulbs? These bulbs can it can keep sending light out, but what they're not doing is sending the UV out within potentially 6 months, sometimes as short as 4. But I would do a UV light bulb change every 6 months to make sure that you're negating that possibility. But also, where is that light in comparison to, example, a reptile? If it's too close, you could damage the retinas. If it's too far away, you do risk not getting any UV exposure at all, which isn't really doing any good. So you do need to look at these things. The diet substance, look at that, but also the frequency that they're feeding it. For example, if you have someone who is saying they get the occasional waxworm, okay, waxworms, a bit more sugary, more high in fat compared to some other things. When they say occasional, do they mean once a week or do they mean the occasional hour? And then you really need to have a little bit more detail in terms of what these guys are feeding. Obviously, fundamental history taking again, I'm not going to go through that with you, but one thing I do find often is you need to ensure that it's the primary carer who is answering these questions or has told somebody else about these questions. They make nice little guides these days on exotic animal history taking that you can even give to the owners in advance or afterwards if they're coming in suddenly. And I do think sometimes that can help. I've seen a lot of family miscommunications, particularly, for example, a teenage boy with a reptile whose mother brings it into your practice because he's unwell. The teenage boy knows everything about this reptile. Mom doesn't know a thing. That's just one of many examples, but do consider that. You need to determine the experience level of the owner. Some of these owners talk a big game, but they don't know what they're talking about. I've also had people who have never had a reptile before in their life, or a bird, etc., and who have done so much good investigating that they know exactly what they're doing because they know where to look. Don't forget other animals at home. You've got a presenting problem. What's going on with the cage mates? Are they showing anything similar? Also think about what other species are there. Do you have a ferret in with a rabbit? Could be a concern. Do you have, there's certain species of parrots that produce a fine dust. That can actually be irritating to other species of parrots. So something to consider there is the overall picture. And consider other stressors. I'll talk more about stressors when we get to one of the avian slides, but it is something to consider. What is that home environment like? Examination. So some of the things, one of the main things I want to mention is something that Ian somewhat mentioned there at the end, is if you have a bird in your consult room, one thing that a lot of us would do in the exotic field is we're talking to the owner, trying to be calm. Out of the corner of our eye, we're watching that bird, because as Ian mentioned, that bird has the defenses up initially. As things go on, the bird settles into the environment, they can start showing you that they are feeling unwell. Now, whether you put them sort of what I would call backstage, sorry, I used to work at Disney, so these terms have kind of stuck, but back behind the scenes in the treatment area, or if this is in the consult room, it does help you to sort of gauge what's going on and if the bird's a little bit more unwell than it's showing. Obviously, examine head to toe. One thing that I find people often miss is an oral exam. Particularly with reptiles, but I would say across the board, I see a lot of people who they say, oh, this is wrong, that's wrong, what's going on? Did you look in the mouth? A lot of people haven't. Obviously, you're going to approach looking in the mouth or the whole overall exam differently, whether it's that small little snake in the upper left or that big snake in the lower left. Those will be very different approaches. There's different ways you can look in the oral cavity. One thing that was told to me years ago that can work if you've not got anything perfect, probably not going to work in the big guy down there, but that little guy, you can use things like business cards even if you're in a pinch, and that just helps non-traumatically opening that mouth to see what's inside. You need to know a bit of what normal looks like. You can get a big difference between the way the skin or feathers look between the species, but you can also get seasonal differences. You can get momentary changes. If you see a snake come in with cloudy eyes, is there a problem with the eyes or is it going into shed? So just be aware of what is normal for these guys. Auscultation, admittedly, cardiac auscultation is easier in mammals than in birds and, mammals and birds rather than reptiles. Avian species can have a really high heart rate, so do be aware of that. Sometimes that can be very hard to count depending on what species you have in front of you. You want to listen for any increased respiratory sounds, but in addition to that, I'd say check for increased respiratory effort. Just because you don't hear any sounds doesn't mean that they're not having difficulty. I think of egg peritonitis chickens in that type of context. If it's bad enough, reducing that coelomic cavity space, increasing that coelomic cavity space to the point that you're reducing any sort of ability to get air in. Rabbits. I'm not going to talk a lot about rabbits because, again, a lot of people here do see these guys all the time, but there's a couple key takeaways here. They're very popular pets, as I mentioned. A lot of you out there are feeling quite comfortable with these guys today. The Rabbit Welfare Association Fund has a lot of great guides. I'm going to show you one in just a second in terms of feeding. Some common concerns you guys see: gut stasis. Question is what's causing the reduced motility there? Is this something where they're painful and therefore they're having more of just a slow transit time? Or is this something where we actually have an obstruction? Those will have very different approaches. Obviously, if we have something like an obstruction, we do worry that this is going to go more to a surgical case. So do keep that in mind. Teeth are a big one, and I'll be mentioning those more in just a second. One thing I do find people see a lot of is pododermatitis, and there can be a number of reasons for that, but that can be a problem with the bedding. It can be a problem with enclosure size, and they're just sitting all the time. But it can also be a problem where that individual, for whatever reason, just isn't wanting to move around as much, and they're just sort of for lack of better words, not moving around as they should be. And I know a lot of you guys do see a bit of conjunctivitis in these guys. So, always consider the rabbit when we're looking at, or always consider the diet when we're looking at rabbits. For those of you that don't know, you want mostly a hay or grass diet. We need to keep those teeth continually being worn down. Not that they can't have other things, but these individuals that are in complete muesli diets, this is a big concern for us, and obviously it's going to lead to dental issues. Beyond that, do remember that dentistry in rabbits is not just the spurs. That's one of the biggest things we look at. Obviously, you want to do an oral exam, and sometimes the problem's staring you right in the face. But there's plenty of times where you need to also consider what's going on with the roots. And we do have plenty of times where there's overgrowth that you cannot see, okay? Now, good radiographs are good at diagnosing this. There are different methods you can do to treat that, some of which are more advanced than others. But it is something to consider. And I want to point out that when you're taking radiographs of the rabbits, do look at taking oblique views. I've had a lot of people send me radiographs over the years saying, what do you think of these tooth roots on this rabbit? The problem is when you have superimposition of one side against the next, you can only partially tell what's going on with this picture. So what you want to do is you want to do oblique views. Just do a laser at all? No. It's worth asking. So as you can see on the right, there is tooth root overgrowth down there around the jawline. Now that wasn't able to be felt. Sometimes you can feel it, sometimes you can't. But had we not done the oblique view, we might not have been able to see that. Now, there are different methods of basically drawing lines from the tympanum all the way sort of, I need to look it up again because I can never remember the exact marker, but towards the nose. And what you're doing is drawing a line, and if their tooth roots on the maxilla are above the line, you do have a concern that way. Additionally, there's lines that can be drawn down as well. And what that does is that allows us to tell what the type of overgrowth situation is. But this is one of my key things I want to mention about with rabbit dentistry that I do feel people miss quite a lot is the oblique views. Rodents, I'm just going to mention them briefly. They're not just small rabbits. Each species has different specifics. Always be sure to, again, check diet and husbandry requirements. Dental is often a presenting concern. I would advise, though, if you're doing dentals on chinchillas or guinea pigs, be cautious how much you open the oral cavity. The reason why I say that is because their musculature there just seems to be a bit tighter, and there have been plenty of cases where people have opened it a bit too wide, caused damage to the musculature, and then we have an individual that doesn't want to eat for another reason, and those cases can be quite concerning sometimes. Ferrets. So this is my only slide on ferrets tonight. I just want to mention them. I'm kind of brushing over the mammals a bit more than I am the other species. But ferrets, they can have a long list of issues, as I'm sure a lot of you guys know. Adrenal disease, insulinomas, GI disease, lymphoma. We can keep going here. One of the things I want to mention here, I've specifically left a lot of the medical and blood work cases out because I knew Ian was talking about blood and I knew more about blood draws, but I just wanted to make sure I wasn't sort of stepping on his toes with anything. But blood work can be very important on these guys in terms of determining what's going on with them. With ferrets, this can be a whole big long chat in itself in terms of all of these different issues. Ultrasound can be very useful depending on what presenting problem we have, and advanced imaging can help as well. Birds. This is a larger topic than most, but I will be going into birds a little bit more here. Parrot diets are a big concern for me. There's been plenty of times where I've had a patient in, I knew he was on a sunflower seed diet. I told him it was probably going to be a problem with hypovitaminosis A. Blood work helped prove that. I told him this is what it is, and the guy says it doesn't make any sense. He's been on a sunflower seed diet for 20 years and he's been fine. And what you have to get across is, well, that's the point. He's increasingly had a problem because his dietary requirements aren't being maintained. Unfortunately, there are a lot who get this wrong. You do have to look at the different species. You're going to treat, a budgie different than you're going to treat an African gray. There's some similarities there, but there are differences between the species. These nutritional deficiencies can lead to big problems as time goes on. Their anatomy and physiology is very different from your mammals, obviously, but do keep in mind that just because they're different doesn't necessarily mean they're scary, okay? Unless you have a big macaw coming out your face to take off your nose. That might be a different story. I didn't mean to scare you. Some of many concerns I'll mention here is bumblefoot is a concerning thing for these guys. Feather destructive behavior, very frustrating cases, but I'll talk about that in a little bit more detail here. Fractures, and I want to mention critical patients because birds can go downhill very, very quickly. So, pododermatitis, these can be minor, these can be major. I've seen all of the spectrum here. The minor ones, all of them take a bit of time. All of them take a bit of time to resolve. The minor ones obviously are better on the spectrum. Some of the major ones can have severe bony involvement. You can actually have bone degradation to the point that you do need euthanasia. So if you see a case like this, I would consider doing a radiograph on that to see what's going on with the digits, see what's going on with the bones down there. Causes of this, with your talented individuals, you can get punctures, obviously. A lot of it is poor weight distribution. If you have an individual with a leg that they're not using as much, they're almost always going to get bumblefoot on the other limb. Sometimes cleanliness of habitat is a factor here. And you can have nutritional origins to this as well. I would say that's a little less common, though. As I mentioned, they can be lengthy cases. Some of them are truly just simple debridement and bandaging. There's different methods in terms of fixing that weight distribution on these guys. And you will have a long situation where you're doing repeat bandage changes on these guys. You also don't want to leave their digits sort of in the same position for far too long. Feather destructive behavior. As I mentioned, these are frustrating cases. Why? Because they have a number of different causes, some of which are behavior, and that's a little bit more difficult to diagnose. So you can get different reasons for this, including diseases, ectoparasites, diet, husbandry, stress, if there's a stressor in the house, or indeed severe boredom. This little guy, he was feather plucking. We wanted to do a bit more of a workup. Owner wasn't so keen. Owner was hoping for a quick fix. Wanted to have a collar on him. A lot of collars on these guys don't work well. That guy's been in there not even 5 minutes. He's already taken it off. He came in the next day and the whole thing was gone. So keep in mind, they do make different types of collars. I'm not a big fan of these. I try other methods as best possible, but there are collars out there that can help, but it doesn't really get to the base cause, because as soon as you take that off, if you've not treated that base cause, he's going to go back to tearing his feathers out again. How would you approach this? Start ruling out ectoparasites, start ruling out disease, discuss environmental enrichment. If this is a parrot that is just sitting in the corner all day with no toys, no sort of games to try and get treats out of, things like that, it might be something where this is just a behavioral case. I don't mean just a behavioral case, because those can be quite tricky, but it may mean that there's not a deeper problem here. And you need to assess the habitat. I'm not saying you need to do a home visit. Pictures can do on this. But sometimes there are even unique stressors. Excuse me. For example, if you have fluorescent lights they technically flicker. Our visual abilities just don't catch that. Whereas birds, they can see good enough that they see that flicker, and it's like they're in a strobe light haunted house. So that can actually cause a problem as well. That's just one of many examples. Orthopedics. So fractures can be rewarding cases. They can also be very frustrating cases. If you do have one of these guys come in, you want to ensure that you're providing pain relief, obviously. You want to be able to, if this is an individual that's not using that leg and things seem pretty stable, you don't necessarily always have to splint, but I would probably consider something to reduce the mobility of the fracture site. You definitely don't want something where a bird's panicking and thrashing everywhere and that thing's constantly moving back and forth, because that's going to potentially cause other damage to soft tissues as well. But some of these do indeed require either splinting or pinning or external fixation. Some of these, it depends on the fracture. It depends on what we're looking at. Some of these guys with minor fractures do fine with splinting. Some of these guys do indeed require situations like what you see up here where we are pinning something. One thing I would mention though, if you are going to do a splinting in practice, make sure that you're not leaving the splint on and holding a joint at a certain angle for lengthy periods of time, because avian joints have a tendency to fuse. In fact, it can happen quite quickly. I'm not talking a matter of, months. I'm talking about, a matter of, less than weeks. So it is something where if you are doing that, let's have a discussion about how frequently you need to be changing that splint carefully and getting some mobility into those joints. Wanted to mention emergencies. As we've mentioned a couple of times, birds and many exotics indeed hide being unwell. By the time birds present as unwell, there's often a big problem here. If you do have a respiratory patient, I feel that oxygen therapy is a must. Supportive care, IV fluids if possible. As Ian mentioned, wing vein is a good one to place an IV in. That can be fiddly and take some practice, but I do feel like that's a real good one to go for. But if you can't get an intravenous catheter in, what I would consider doing is at least giving subcutaneous fluids. There's different places you can do it, but I'd advise inguinally. The only thing is do make sure that you are only skin deep and you're not going into any sort of air sacs, because you can swiftly turn a critical patient far worse if you would do that, obviously. You're really just trying to get the bevel of the needle under the skin and just let the fluid do the rest of the job. Nutritional support, this can be for a number of different species, but cetaceans, for example, just as one example, they can have a high metabolic rate. So if you have an individual hospitalized who's not eating, you do want to consider crop feeding them. You can use something like Emerade, which you can make it to various consistencies depending on how much water you put into it, but there are certain guides to do it appropriately. Different ratios, they make Emerade carnivore, herbivore, piscivore, and depending on what species you have in front of it, you can do a different combination of these to sort of get the formula that you want. But you do need to be cautious there. You want to make sure that you're crop tubing them, but not giving them so much that is backing up and then they're aspirating. That could indeed be a death sentence in these guys. That's not to scare you, that's just to say be cautious. Basically, there are different guides online with this as well that can tell you, per body weight, how much should you be giving per feeding and how frequent you should be doing these feedings. Lefebvre has good guides on these. Endoscopy. I feel like this is quite underutilized with exotic animal medicine. This isn't my image. This image belongs to Steve Divers at Georgia. He runs a real nice endoscopy course for exotic animals. If I'm using the guy's image, I feel like I should plug his course. This is just a brief overview of some of the things we can see in endoscopy. Some of you might feel comfortable doing this in practice. If not, and you're looking for a diagnosis or a workup, this is something we can do on a referral level. But as you can tell here from just these, the endoscopy really is quite useful. There's so many times where other forms of imaging don't show us what we need, but this actually is quite a swift way of determining what the issue is, getting the biopsy, and determining the problem. Reptiles. For anyone who knows me, I love all exotics, but reptiles and fish are where I have a lot of enthusiasm. Majority of these guys have a common theme with their problems: nutritional and husbandry issues. I know I sound like a broken record, but reptiles really do have a big problem with that. There's a lot of people who I feel do impulse buy these things. They don't do their research, and then next thing they're trying to get us to fix a very complicated problem. But it doesn't mean we can't fix that. Each species does have very specific requirements. I would do a lot of investigation in terms of what different species requires what. Oftentimes we unfortunately aren't meeting this in a captive setting, even under better conditions than some. Diet and husbandry, obviously, I know I keep saying it, but they are a vital component here. Some of the cases I'm going to show you and what we can do, either in practice or on referral, coming up here. tortoise dog attacks, prolapses, your metabolic bone diseases, dental disease. I'm going to talk about some swollen snakes because I do feel like people see those some, and egg binding and follicular stasis. So I don't know how many of you have seen tortoise dog attacks. I feel like I went through a run of seeing quite a number of them actually. And they can go from quite minor, little abrasions on the side of the shell, to quite severe, like our guy on the left there, which has coelomic exposure. So what do we do with these? We want to make sure we're cleaning these wounds. We want to make sure we're providing pain relief and antimicrobials. We want to make sure that we're doing regular dressing changes to make sure this is healing well. Some cases, wasn't a dog or cat, but I have seen it where sort of ascending infection has gone up the shell and done quite a bit of damage for a different reason, admittedly, but that could indeed happen in this case as well. And if you do have an individual like you have on the left, whether it's from a dog or cat, it's going to sound strange, but hit by car. When I was in Florida, there was a lot of gopher tortoises that would be hit by cars. You can do shell reconstruction on these guys. That little guy is going to have his lungs exposed, basically. It doesn't really sound like a fun experience to me. So I would probably look at trying to cover that as best we can. Prolapse, this little guy, he's full grown. This is one of the smaller patients I've dealt with. I don't actually have an image of the prolapse. I was taking a bunch of photos to show how small he was, but he's an interesting little case. If you do see a prolapse, the question you have is, what was the cause? It's typically caused by tenesmus. They're pushing for some reason. In this guy's case, we did want to do more of a workup. If I'm honest, I don't remember the whole reason why the owner didn't want to, whether it was due to cost or sheer size, because he was tiny. But we didn't look further. I feel like it was within the next 2 weeks this guy passed away, if not that week. And on post-mortem, he actually had an intussusception, so that's why he was pushing. So do consider why they're pushing. There are times where people don't want me to investigate further. I've replaced the prolapse. Everything went fine. I never actually found out what the issue was, but you can have problems with parasite burden causing this, and indeed reproductive issues. But they do quite well. You want to assess for any devitalized tissue. If you do have devitalized tissue that's quite extensive, I think euthanasia needs to be discussed. If it's less amount of devitalized tissue, you can do a resection and then replace it. Obviously, there's always concerns with doing these types of surgeries, but it can be done and they can do well. But if it's a simple replacement, you do a purse ring suture, make sure that they can still defecate through that, and they usually do quite well. So, metabolic bone diseases. I know this is something a lot of people think about the moment they see the word reptile. So a number of people consider metabolic bone disease as one thing. It's more of an umbrella term for a number of different diseases causing what you're seeing on your radiographs. But what you're typically seeing in practice is what we know of as nutritional secondary hyperparathyroidism. Now, this is typically a failure of diet and husbandry, once again. It's a complicated biochemical process, but basically we're having a problem with any of these four things, if not all of them, and that's calcium, vitamin D3, UV lighting, and temperature. If you can get some of these right, but not the whole picture, for example, if you get all that right, but you don't get them to the preferred optimal temperature zone, they still might not be utilizing these ingredients well. So you do need to look at that whole picture. Now, I do know a number of people who think, what's the point? They're not going to do well. And some don't. I'm not saying I've never recommended euthanasia for some of these guys, but you can actually fix this more than a lot of people think you can. If you start correcting some of these items, and if you have a case, let's chat, because there's some other things you want to add in here too eventually, in that type of case, such as calcitonin, but you can fix these, but it does take time, effort, admittedly some cost, and a bit of treatment, but you can fix these guys and turn them around, depending on the severity, though, I will say. I mention this one not because I see a ton of it, but because I feel like this also drives home, my look in the mouth point, but I feel like people often think that dental disease is just a disease of rabbits. Usually, if you see, for example, a bearded dragon with dental disease, it's typically a dietary issue. I know that's a common theme tonight. But typically it's due to soft or sugary foods. I remember everybody in the practice laughed at me the first time I did a dental scaling on a bearded dragon, but he had, for lack of better words, minging teeth, and we did a dental scaling and they looked quite nice afterwards. I've also had it where I've opened a bearded dragon's mouth and I've had quite a fair bit of teeth fall out at me. So you do need to make sure that you're trying to get these before they turn severe. Some of the more severe cases do require more intensive treatment, obviously. Snakes, this is another one sometimes people have phobias about, but interestingly I've not seen the same type of phobias I see with birds, even though snakes are more known for that. Common presentations, respiratory issues. There can be various reasons for that, whether it is lack of ventilation within the enclosure, whether it's a viral disease starting it off, but for whatever the reason, you typically also get secondary bacterial issues if that wasn't the primary cause to begin with. You want to look at the husbandry, you want to look at potentially treating with antibiotics if you feel there's a secondary bacterial, and consider viral testing for these guys as well. Burns, we see quite a lot of in snakes. This is a failure of the enclosure. So with the burns, what they're doing is they are wanting that source of heat more. They are going up and wrapping around your heat lamp. Next thing you know, they've got quite severe burns. Even in some of my more severe cases, I feel that these guys do quite well if you approach it early and well. You want to try and debride away any dead tissue. And one of my favorite, you want to clean the wound, and one of my favorite things is silver sulfadiazine ointment. So your flamazine, I believe, is the main trade name at the moment, but it does absolute wonders for these cases. I will say though, let's say you're telling the owner to put this on, for example, once a day or twice a day. I would say try and clean some of it off before the next application, because I've seen some people who just kept applying a very thick layer and it just caked on to the point where I wasn't convinced the new treatment was doing anything because you had so much that they had just left on the snake. But also, if you're cleaning that bit off every day, you're also sort of wiping away any other dead tissue that does sort of arise before they're coming back into practice. One thing I want to mention, because I find these cases interesting, but I have seen a number of these, is what we would just call a swollen snake. I did not do this balloon animal. That came from Google. Why would a snake be swollen? I'll admit, typically I see these more in the distal snake, but I'm about to show you one that isn't. Common causes for this: neoplasia, constipation, dystocia. Issues such as that. Possible diagnosis or diagnostics to figure that out. Radiographs show some of it. I find ultrasound being quite useful. If you do see something on ultrasound, in both the cases I'm about to show you, we did do a fine needle aspirate. One came back conclusive, the other one a little less so. And you can consider CT and MRI. Surgical investigation and resolution is common in your swollen snake cases. So this is one of two corn snakes I'm about to show you. I only have a full image of one of them. I don't know if you guys can appreciate, but in the top bit there, sort of mid-snake, if you will, there's a swelling. Now, the previous ones I had seen were all more, distal snake in terms of their swelling, which will be the second case I show you here. But what I did is, when I popped the ultrasound on that, it just didn't really seem like much. I couldn't have it. There was no defined abnormality. I did a fine needle aspirate. It came back as fatty tissue. I figured that was just, error on my part, or you guys do FNAs. You know how that can often be the case. But actually what this was infiltrative lipomatous tissue. So although the lipomatous tissue in itself was benign, what these can do in some of these snakes is actually, this was infiltrating through the muscle layer and everything and causing quite a bit of havoc. So we debrided a lot of that out. I had to put the muscle layers back together, and this guy did well. I'm not convinced I got all of it. Again, it wasn't overly aggressive. I feel like it was slow growing, but that is one case that kind of surprised me at the time. I have seen more since that. Here's another little guy, which I did not expect. Now, I could tell there was something there. I did think something neoplastic. This is not the same snake, obviously. This is further distal. I do wish I had a photo of the snake afterwards that I could show you exactly where this was. But this is basically the kidney. So we had to do a nephrectomy. You can see normal kidney tissue on either ends of the growth. And when we went in surgically, this is the one that had an FNA that was fairly inconclusive, I do think because of what was going on inside the growth itself. But the nephrectomy was a bit of a surprise. The snake did very well. I feel like the snake was about 18 to 22, somewhere in that range. In the wild, these guys can live about 6 to 8 years. I have looked it up after this. They can live, the longest reported one was 32 years and some months in captivity, but I'd say that's less common. So I did have some concerns about this guy. Obviously, it explains why there is a neoplastic process going on here. But he did really, really well through surgery and thereafter. So if you see reptiles in practice, I'm sure you guys have seen one or two of these. If you know, egg binding and follicular stasis are treated a little bit differently. But radiographs can diagnose your egg binding. Sometimes they can diagnose your follicular stasis. The issue is sometimes you just don't get that same definition that you do with those calcified eggs. There is a slide next where you can see the follicles quite well, but I've had, there's actually an individual, he's no longer there, but at Crown Vet, he showed me a radiograph, and I said, look, I'm not entirely convinced this isn't follicular stasis. I popped the ultrasound probe on there, and indeed he did, and it was. He was actually quite keen to try the surgery himself because he wants to do exotics back in his home country, and everything went quite well eventually after the owner showed up after the third attempt. But yeah, these are things where if you do have eggs in the lizards, you can try oxytocin. It is variable depending on species, I feel, but even case to case, whether the oxytocin is going to work on these guys, which is different from your tortoises, which I'll talk about in a moment. But I do feel many of these guys do go to surgery, like your bearded dragon down here. Now, your bearded dragon, as Ian mentioned, they have a ventral abdominal vein. So it does run just down the middle. If you are ever going to surgery, do make sure that you go to the side a little bit. You just want to avoid it if you can. So, chameleon complications. I like to mention these not only because it does show us another image of, you can see the follicles on this guy, but the only individual I've ever had regrow an ovary was a chameleon, and I just want to mention why. So, in reptilian species, if you leave even just the tiniest bit of ovarian tissue, they're going to regrow the whole ovaries, and that's exactly what, I'm not sure if it was this one, but one of my little guys did. What's happening here is these guys are very flat, you know, what would you say, dorsoventrally speaking. It's not like we're going in their ventrum, we're going in the side. So to get to the other side, you're having to really push a lot of things out of the way. It's a little bit more delicate work, and unfortunately the ovaries like to sit around a lot of very important vasculature. So you're trying to be gentle yet efficient. So sometimes that other side, it's usually not the side that you've incised on that you have a problem with, it's usually the other one. Again, I've only had one do this, but I have seen several individuals throughout my career who have told me they've had this as well. I want to mention colonian reproduction because egg-bound tortoises are very common. These guys, fortunately, oxytocin usually works quite well in these guys. So several doses of oxytocin, if not the first one, and those eggs usually shoot right out. I will say that's not always the case, but it usually is. Sometimes it does go to surgery. Whereas follicular stasis, at least in my experience, I don't see this as common as egg binding in my colonians. That does, to diagnose it, require an ultrasound typically, which you need to get an ultrasound probe in the prefemoral fossa to try and angle it the right way and see there. And those indeed can be surgical cases. So, how do you take something firm out of a tortoise? You've got to do a transplastron coleotomy. Now, I'm going to talk about that prefemoral space again here in just a second. But, for example, if you've got something like a bladder stone, if you've got something like you are concerned about a foreign body, not that I've seen one in a tortoise, you do need to consider going in through this method, which is a big op before you're even incising into the coelomic cavity. You do need to be careful of your landmarks. For example, that's cranial, that's caudal on the left image. The pelvis sits right there, so if you go too caudal, the pelvis is going to be in your way. You don't want that. But if you go too cranial, you're not going to be able to get to some other structures. And plus, if you go too cranial, you're going to be going right above where the heart's sitting. So if any of you have Doug Mader's reptile book, if not, I do recommend it for exotics, but it does a really good job of showing your landmarks. If not, I can always chat to people about where to go. I've done a number of these now. First one took me about 45 minutes to get in because I was so scared. Now I can go in within about 10 minutes and be doing the surgery. This is an aquatic species. Keep in mind, you don't want these guys to go right back in water. The reason why I would say that is because you are putting on an epoxy resin, but just in case you don't have that tight as you think, I would advise dry docking these guys for a little bit just to make sure that the tissues do heal so that you're not getting a bunch of dirty water into the coelomic cavity. Where possible, if it is something like a follicular stasis, I would go through the prefemoral fossa if you do have the space. Now, depending on the species, the size, that might not be an option. So you might not be able to do that at all. It still might end up a transplastron ciliotomy, but I do want to mention that as a method because it's less traumatic, healing time's quicker. It is something to consider. I like showing this image. Anyone have any idea what that is? Usually people get half of it. No one? So, first half, that's a stone in the bladder. Anyone have any idea why it's got a halo around it? So this is what we know as a pseudocalculus. Basically, this little one laid an egg down into its cloaca. Instead of coming out into the wide world, it retropulsed it up into its bladder, and it acted as a nidus of stone formation. I thought this was quite an interesting case because I really loved the image. This was actually my first plastrotomy. It went quite well, but this is the one that took me 45 minutes to get into because I was afraid of the lateral veins. That's what came out. Now, I cut that a bit fine because that almost didn't come out of that hole, and you do not want to keep cutting off bits of the shell. So you want to make sure you get the right amount at the right time. So this came out fine, but it was very tight, and I panicked for one moment thinking it wouldn't come out that way, and I'd have to get creative. Now, that is something that would have never come out of that prefemoral fossa, but if this was a smaller stone, I would have considered doing it that way. But this was quite a fun little case once it was over and everything healed. This one did very, very well once we got that stone out of there. These are the two patients you just saw. One thing I like to mention is if you do have any of your colonians that aren't eating, if you're putting them under anesthetic or sedation for any reason, I would consider putting in a feeding tube. These guys do great because what you're doing is you're providing them nutritional support on your own. Whether they eat or not is irrelevant at that stage. Eventually when they start, because it's an esophagostomy tube, when they start eating, it just goes right past it. It's not going to hinder that at all. And you provide a little bit of temperature support, nutritional support. A lot of these guys can turn around quite well, and we can go quite small with this. So that little guy, that upper right image, that's in somebody's hand, and if you notice, you can't even see the fingers. He was a tiny little one that I don't think the bottom three images really demonstrate well. What we do is cut off the butterfly and needle component of a butterfly catheter and placed it that way. Unfortunately, he did get his leg over the tubing. I wasn't really concerned because it stayed in. But ideally, I would have tried, I kept trying to get it up, but he was a very determined little one despite the inappetence. A couple final points here. I want to mention amphibians. If you do have an amphibian come in, you need to be careful about the skin. They do have that permeable skin more than the rest, so I'd always wear gloves so that your own hand oils or any creams or moisturizers you're using don't end up on the amphibian. This little guy, actually, the owner witnessed what happened. One of the insect prey items bit him on the foot. That then proliferated into a bit of a concern. This one is another one did really well with your flamazine, silver sulfadiazine. Kept it clean, put that on it, and it healed up quite well. So I'm a big fish person. I'd be not really doing myself any justice if I didn't mention the fish. You can do more on these guys than you think you can. Any of the surgeries you guys do on dogs and cats, maybe not all of them, but a lot of them we can do on, whether it's going into the gastrointestinal system, whether we've got a reproductive issue, or indeed tumor. Tumor is one of the most presenting complaints. As you can see on that fish with the eye on the left, we had to enucleate that because there was virtually no eye left. They can also have buoyancy issues often reported, and they've got a swim bladder, so that can be a problem with the input or takeaway of air going into it, depending on what the issue is. One thing I will say is always check your water quality. Even if the tumor's staring you in the face, check those water quality parameters, because a lot of people do get that wrong, and that can cause more stress on the fish in terms of healing processes. Also look at whether this is a full tank issue, if there's multiple individuals. If you have a disease process coming through, I would look at doing skin scrapes and gill clips. This isn't skin scrape like you do for Demodex. You're literally just taking that top mucus layer away and looking for any parasites. And the gill clips, you're not taking the whole gill off, that'll kill them. You're just taking the little distal filaments off. Don't worry, they'll be fine, it will grow back. I also want you to think about invertebrates, guys. These are animals too. I like this case because with exotics, you sometimes need to be creative. There is the sort of standard way we all do things, and then there's we've got to think outside the box. So this little boy dropped his snail. He's very worried about his snail, and we needed to reconstruct it. I got this method from one of my invertebrate enthusiast exotic friends down south. Anyone have any idea how you fix this? Or anyone want to throw out any idea? There's nothing too silly. Sorry? 3D printer. I like that. I didn't get that fancy. I cut up a Coke bottle. So I cut up the plastic from a Coke bottle and used epoxy resin to create something to basically keep the exposed bits of the snail from the elements. What you see on the right image there is you can see fluid within it. You can see little bubbles at two spots. That fluid is actually fluid that was sort of produced by the snail itself. So what we did was just, and the little boy said fluid like that came out when he dropped the snail. So what we did was we just allowed that snail to have a covering over that again. Now, this little guy, unfortunately, he did go through a lot. He probably only lived another week or so, but I admit that was probably longer than if he had no shell at all. In the future, there might be some little ways I could adapt this further, and maybe some more I would have done with treatment. But do keep in mind, sometimes it is a matter of thinking outside the box. So, a final thought or two. I get a lot of people who send me radiographs on a conscious animal. And the reason why I mention this is because if you send me a radiograph like this, sometimes it's very practical. Sometimes very practical. I don't know if you can see there, but the fracture is very obvious in this guy. And I've done plenty of conscious radiographs, and my problem is staring me in the face. But if you aren't doing a sedation or GA on a lot of these guys, you're not getting a good quality radiograph, and you can't really tell what's going on, like in this guy. This is one a friend sent to me and said, "Can you tell me what's wrong with this little gecko?" I said, "Absolutely not, because he's squiggly, exposure's poor, image is blurry, and you can't make heads or tails of that." I mean, you can tell where the head and the tail is, but you can't really make heads or tails of any diagnostics there. So just want to put that out to people that sometimes a GA or sedation with x-rays really does go a long way in terms of helping with determining what the process is. I do want to mention, in terms of Scottish vet referrals, we are starting up an exotic animal referral situation. Any case is welcomed. As I mentioned, some people are very less keen to do any sort of reptilian or avian cases, and I'm happy to see anything. Up to the complex stuff where you guys have done quite a bit, and then feel, this is a little bit beyond my ability at this stage. Some of the things I mentioned there that we can do is endoscopy, dentistry, and orthopedic. Admittedly, any sort of medical cases as well is an option. When will this be starting? Imminently. We just have a couple little things to work out still, but this is something we'll be having up and running here very soon. So don't hesitate to let me know if you guys have any concerns. I wanted to say thanks. This was a case we had recently. This is Marlowe. He is an eagle owl from Blue Highland Wildlife Rescue. I help them with cases from time to time. And this was the amazing ophthalmology team that fixed his cataracts. And he also had a keratectomy in the other eye. He was blind for a very long time. We just did this a couple weeks ago, and I'm happy to say Marlowe can now see, which he's not been able to do for many, many years. His quality of life was declining, and I'm happy to say he's now a very happy bird again. So he's still in recovery mode, but he's doing quite well. So if there's any questions, let me know. I do know this was a very general, brief overview. What I'm trying to do here is tell you guys what you can do. Some of this might be stuff that you guys are already doing, if not plenty of it. But it also helps us start off the path on terms of what else you guys want to hear in terms of exotics talks. And also, in this sense, any of the stuff that you've seen tonight where you think, okay, that is beyond my ability, it lets you sort of assess that in your own mind and determine when you decide to do a referral as well. Okay? Thanks, guys. Any questions at all? No? Cool. Mm-hmm.
Well, that was very interesting, even for me. Learnt loads, and I've probably got a lot more to learn now that Darren's joining the team. So thank you, everybody, for attending, and just a massive thank you to VPG for sponsoring us tonight as well. We have got feedback forms on your table. We'd really like to get as much feedback as possible. It just helps us with any future CPD. So anything that you're really keen to learn, just write down and we can try and sort something out for you in the future, because we will be holding them as regularly as possible. So thanks, everybody. And please finish the pizza if there's any left.